And I have 11 o'clock, so we will get started today with our bi-monthly, every other month Swingbed education program, which typically features our national presenter, Kerry Dunning. But before we begin today, I want to introduce myself for those on the call that do not know me. I'm Becky Royer, and I am a contractor with the State Office of Rural Health and lead the Medicare Beneficiary Quality Improvement Project program, which Swingbed is a part of. So we're very excited about today's program. I think it's a topic that many are wanting to work on and improve, as each and every one of you are striving to build your Swingbed programs. We do want to thank the Indiana State Department of Health that supports these education programs, and we're able to provide those free of charge to you. And also for the Indiana Rural Health Association and Carolyn Miller for kind of supporting the Zoom platform in the background and making sure that all functions well. We do want you to ask questions today as those surface, as we're anticipating that there will be some questions. So you can do that by hovering at the bottom and either unmuting your line and asking the question. We try to keep the sessions as informal as possible, so feel free to jump in. You can also click on that participant list and you can unmute yourself, as well as the area where there's a microphone to unmute your line, either by hovering at the bottom of your screen or at the top, depending on which type of computer you have. I encourage you to open up the chat function. I would like for you to chat in your name and your hospital. We do like to take attendance and want to make sure that we have attendance correct. And sometimes when individuals log in, it is not by their name. It's by some identifying number, and so we're not sure exactly who those people are. So if you could open up chat and do that, well, I'd really appreciate that, as well as we will monitor chat and make sure that we answer any questions that you chat in as well. So we'll get started today. I'm going to turn it over to Kerry Dunning. Kerry is our national Swingbed consultant expert that knows the ins and outs of post-acute care and has just been a tremendous resource for us over the last couple of years. So Kerry, I'll turn it over to you.
Thank you very much. Good morning, everybody. I'm glad you're on. This is a topic that more than one of you have asked for some expertise. So that's what we're doing today. And Amber Boatright's on, and she is a physical therapist. So she is one of ye. She graduated with a bachelor in
45 minutes.
Specifically for therapy, but more importantly, as you know, these days, she has, all of you are being asked to do so. She attended Medical College of Georgia in consortium with Armstrong Atlantic State University, where she got her doctorate in PT in 2009. She is a certified fall prevention specialist, and she also has used her expertise in all the multiple settings. So why I asked Amber to join you is that because in our critical access hospitals, you have to do inpatient, outpatient, swing bed, and I don't know what else you guys get asked to do, but it is a catch-all job, and that is the expertise that Amber brings to the table because she's held multiple roles, but she is also currently in the position of a clinical specialist for Bencura Rehab, which is a rehab company, I think mostly in the Southeast, but I'll leave that if I'm wrong, Amber, to correct. And right now she's serving as director of rehab in a rural hospital. So she's doing hands-on care also. So Amber, I'm going to leave it to you to kind of go over the basics. Many of the people online will be therapists, but others are those who are over Swingbed programs in their respective facilities.
Okay. Good morning. Can y'all hear me?
Yes, we can hear you.
Okay. So good morning. Like Kerry said, my name is Amber Boatright. I have to apologize initially this morning. I am under the weather. I live in Southeast Georgia, if you couldn't tell by the Southern accent. But I'm also have a very raspy voice right now. It couldn't have come at a worse time. But I have got plenty of water and peppermints and everything to try to keep my voice strong enough to get through this morning. But it is, if you've ever seen a meme about Georgia and the climate changes, how we go through 4 climate changes a day, that is 100% accurate. And so we're all of us, my entire family feels like this, sounds like this. We're all hacking. We're sweeping pollen off of the porch and off of our cars. And it was 30 this morning, and today it will be 75 at the highest. So I do apologize for my voice. I'm going to try to get through without having any crackles or coughing fits. But like Kerry said, I am a physical therapist. I have been a physical therapist for 14 years. I have worked in many different settings, including school systems, very short period of time in a school system. I did some home health, but it just wasn't for me. I ended up in skilled nursing facilities and in rural hospitals, where I currently am the director of rehab. So we cover outpatient, we cover acute, we cover swing bed, we cover a SNF that is actually attached to the facility that I'm in currently. We have a SNF attached to our hospital, and we also have a behavioral health center attached to our hospital. So we cover a wide variety of areas. I'm also affiliated with another critical access hospital, and we service that hospital as well here in South Georgia. Very rural area, of course, is critical access. So we have faced a variety of challenges over the years, and one of those being, we've changed our PPS has gone to PDPM. That's one of the changes that we have had in the past couple of years. But staffing has also been kind of a problem, especially since the COVID pandemic hit us. That has been one of our issues. One of our facilities has been very blessed to have been fully staffed, and one of our facilities is not. So we've really had to start thinking outside the box and utilizing all of these resources that we have in the area to try to get our patients seen, get them better, and get them back home. So when Kerry asked me initially about talking about swing bed, therapy in swing bed, I thought of 2 specific things. And one of those is preventing denials, reducing denials. And the other is improving outcomes and reducing the risk for rehospitalizations. Those are the 2 that just stuck out. So I want to first go into how do we reduce denials. So I do know that in critical access hospitals, you don't really have to follow the MDS, which is the minimal data set, which is an instrument that swing beds and swing bed facilities, other swing bed facilities, and skilled nursing facilities utilize, that really just drives their payment. And everyone in the facility, if you've never, had to deal anything with the MDS, we all have to put all this information into an assessment tool that goes to Medicare that determines how we get paid. And like I said, I know that's not the case for critical access, but it is in place for Medicare and Medicaid certified nursing homes. So the way that I treat our critical access hospitals is I try to do the same things for those facilities as far as therapy goes. The requirements, the amount of minutes, the documentation requirements, things like that, that are required for other facilities, I utilize those in our critical access as well. And I really do believe that helps us reduce our risk for denials utilizing this, as Medicare and Medicaid did put it into place. So qualifications for those facilities on the MDS is that if you have a patient come into a skilled nursing facility, a swing bed facility, I'm going to go between the 2, between most of them today, probably. I apologize. We've got several facilities that I'm affiliated with, but In Swingbed systems programs, what they're there for is they're there for skilled nursing, right? So they have to be skilled by one or the other. They have to be skilled by nursing, or they have to be skilled by physical or by therapy services. So what we have to do is we want to make sure that we are treating patients 5 days a week in a 7-day look back. Okay, so every 7 days they have to have received therapy 5 days a week. It is not sufficient in scheduling to say physical therapy will see them 3 days a week and occupational therapy will see them 2 days a week. That daily basis requirement would not be covered in that situation unless there is a reason that you could not perform those on the same day, but it has to be highly documented as to why you could not do that. So just know that seeing someone 5 times a day through 2 different disciplines, PT or OT, ST or OT, is not sufficient in capturing a 5-day daily basis, unless, like I said, there is a reason why you can't see both. Now, sometimes we do have where physical therapy sees them we see our patients actually 5 to 6 days a week. Actually both. They're at 6 days a week in our skilled nursing facility and in our critical access hospital for Swingbed. So we're treating our patients 6 days a week for physical therapy and occupational therapy. We're doing speech 5 days a week. So we are capturing that 5-day-a-week period, but you do have to remember that you can't do 3 for one and 2 for another just to cover a 5-day period. You need to have 5 days. It needs to be that this patient needs to be seen by physical therapy 5 days a week to improve. So that's one thing you need to look at. A skilled day therapy services, they have to be provided, like I said, in a 7-day period. You have to have 5 days. A day of therapy is defined by skilled treatment for 15 minutes or more that day. Okay. So, and it's the total minutes of therapy provided. So if you saw them for 8 minutes for, this time, and then somebody came and they had to go out of the facility or whatever, and you came back and you saw them for 10 more minutes, that's 18 minutes. That's a combined 15 minutes. So for it to be defined as a day of therapy, it has to be at least a 15-minute treatment. Okay, so another thing that we have on the MDS is section GG. Our EMR that we're currently using is Net Health. I don't know if that is something that you guys use in Indiana at your facilities, but we utilize Net Health, and Net Health has the section GG built into the evaluations. And we have to put those in at initial evaluation, at reevaluation, and at discharge. Now, there is an extra section, and I do require all of my staff, physical therapy and occupational therapy, to fill out those section GGs, even in the critical access hospital, because that's really giving you great information. It's great information for you to see that what you're doing is actually working and actually showing you're getting improvement with this patient. Excuse me. It's great for the patient. You can go over this section GG with them. You can say, when we started, you could not even roll over in bed. You required maximum assistance. Now you only require minimum assistance. And our goal is for you to be independent. So we're working towards that. You're making improvements. But it's also great for, it's ways to track your outcomes. So we use this as, payment systems are going towards outcome-based measures. That's how they're going to pay us in the future, is by our outcomes. And this is a good way to track outcomes. We found that since you have to put your initial, functional status, you have to put the goal status, prior level of function goal, and your current assessment status for bed mobility, transfers, hygiene, self-care, bathing and dressing, toilet transfers, things like that. And that's how we track our outcomes. And we take that back to our hospital CEOs, our boards. We take that back to our family members, our patients, excuse me. And we also take it to our referring physicians. take it out marketing. You can market these things around your facility and around your areas. This is what we're doing in our swing bed system. Send your patients our way because these are the outcomes that we're getting.
And Amber, for clarification, Net Health is your EMR system?
Yes, ma'am.
Okay, thank you.
Mm-hmm. And it is a pretty popular one. Kasamba, there was a Kasamba and Optima, and one bought out the other, and now they have meshed. So it is fairly new to us, but there are a lot of features in it that I love. Not marketing Net Health or anything, but they have GG built in, so it's already there. It's easy. You fill it out. You can pull it from your evaluation, and it's right there. You don't have to double add anything. It's just right there. And it's just, like I said, it's great information to track outcomes, and it helps with denials. It helps to prevent denials when you have an insurance company look back and say, oh, they have section GG completed. This is how they started. This is where they are. This is where they discharged. We do see that they made significant improvement. We're going to pay for this claim. What they did was working. You want to make sure that you're doing all this work for the patient. You want to get paid for it, right? So you're given those measurements for functional mobility and showing that what you're doing is actually making a difference. Another thing I have, and I'm reading off my screen, I'm sorry, interdisciplinary team meetings. So this is
Amber,
something.
Before you move on, there is a question in chat.
Okay.
Questioning what section GG means. So if you could just clarify.
Okay. So there's the minimal data set, which is the instrument that Medicare and Medicaid facilities, skilled nursing facilities use to drive their payment. There are different sections in that minimal data set that are filled out by nursing. They cover depression, they cover medications, they cover functional mobility. They cover many, many different diagnosis codes. They show how much assistance your staff is having to provide this particular patient that they're paying for. You're showing them on section GG, which is the physical therapy, occupational therapy section. We're showing them it's got different sections. There's bed mobility. There's documenting how a patient goes from lying to sitting, sitting to lying, how they go from sitting to standing, standing to sitting, stand pivot transfers, toilet transfers, ambulation, 10 feet, 50 feet, 150 feet, looking at ambulation over uneven surfaces. If they're using a wheelchair, are they able to do that independently, or how much assistance? So what you're showing them on section GG is what this person's prior level of function was with all of those functional aspects. And then you show them where they currently are. So for instance, 6 is independent, and that's what they would score. Or if they were dependent, they may score, or max assist, they required max assist, they would score a 1. So your goal, if their prior level of function is a 6, you're independent, and they're starting out at a 1, which is max assist, your goal is to move them up the ladder and get them to that 6. And so
Amber,
mm-hmm.
This Kerry, can I interrupt?
Yes.
Thanks. This is the MDS that everybody but critical access has to use. 16,000 nursing homes, 1,600 PPS swing bed programs must submit the MDS, the tool, to the federal government, among others. There's about 5 directions it goes. It's payment, it's quality, it's everything. Critical access swing bed programs are the only ones not completing it. And this is why I've recommended in the past that therapy departments should be using this as a guide for their documentation. Why? Because 17,000 facilities are sending in data to the federal government, to the payer sources, as to outcomes. And you guys are the only ones in critical access that aren't. So use the same measures. That's going to help you understand where you stand on the program. And I don't think you're that far away from having to do an MDS And I will also say, because Amber's talking about what they're doing right now, we have a new MDS coming out in October of this year, and they are changing from GG to what they call functional gain measures. You'll recognize all the language, but if nothing else, you can go out, download section GG, and then the new functional gains measures and look at them. If your therapist will use that verbiage, that kind of wording when they are documenting, that's what surveyors, reviewers, insurance companies, they know that language. That'll keep you more in line with how they're deciding when to pay you and when not. So Amber, I'm sorry for the interruption, but I've suggested before they use the MDS as a tool in their favor at this point.
And I'll send the link to section GG when I send the recording to today's session out to everyone. A couple of other questions before we move on. Can a patient receive just occupational therapy or just physical therapy for 5 times a week if there is not a need for the other discipline?
Yes, you can, as long as they are receiving a skilled service 5 days a week. However, I would go and look, I would really dig and see what their reasoning is. I use this a lot with like a shoulder fracture. Let's say you have a shoulder fracture patient and they're coming in and your initial screen, you were like, you know what? And sometimes nurses say they get around fine. They're okay. They don't need physical therapy. And we go in and we do a quick screen. It's like, well, they don't really need us, but they have a shoulder fracture. Well, if you dig a little bit deeper, how did they get that shoulder fracture? Did they fall? Okay. So what led to the fall? Now you're digging a little bit deeper into the mechanism of injury here. And you're determining, okay, well, let me actually get into some more things. And I was going to actually talk about this a little later. So here it comes in a question. But, you know, you're looking at the fall risk now. So now you're going to dig into vestibular. You're going to look into medications. You're going to look into range of motion. You're going to look into strength. You're going to look into proprioception. You're going to look into all different kinds of environmental hazards, internal physiological hazards. You're going to look into all of these hazards and say, okay, well, actually, there was a reason behind this fracture. It was a fall. And now I actually have found something that I can really work on in the or for physical therapy as well. And even if you dig a little bit deeper, you can see if there's a cognitive component too. So in that point, you go from only having occupational therapy to having occupational, physical, and speech therapy. Now, I am by no means saying if a patient does not qualify for physical therapy and their own occupational therapy, then no, you know, you cannot justify physical therapy. That's fine. 5 days a week of occupational therapy is fine. But I would just encourage you to really, really dig on these patients and try to see if there is something. You really have to look outside the box. Sometimes I was going on that a little bit lower too. But you really can dig sometimes and find that there are some underlying issues that may need to be addressed that would actually warrant physical therapy and occupational therapy services.
Another question in chat is, how often should therapy be reevaluating the goals?
Medicare requires it every 30 days. However, what we do have to do a progress note every 5 visits. So every 5 visits, we go in and it has to be completed by a registered therapist. So the registered therapist goes in, and it could be a supervisory visit. It could be just for a portion, a little portion of the treatment. They could be being seen by a physical therapy assistant. And I pop in and, it only requires 8 minutes, honestly. And that's your supervisory visit. And we're reassessing those goals at that time. And we're talking with the patient, talking with the staff, and modifying. I reassess every 5 visits.
Okay, that's all the questions in chat right now. And Pam shared a download that kind of has a description of section GG too. So thank you, Pam. Okay. Thanks,
And I
Amber.
think once you see GG, I know it's not, I didn't have it up here, but I think once you see GG, it will really make a lot of sense. It's all the terms that we already use as physical therapists. It's just something to show, it's just a way to track outcomes where otherwise, there's not really a way to go through each goal and say, okay, someone made a 15-degree improvement in knee flexion. That's not really, what's the functional outcome of that? That's not really describing function, whereas section GG does. And I think it's a really great tool to utilize in your therapy services. Interdisciplinary team meetings. So this is a great place to communicate with nursing staff, dietary, your physician, the family member, and the patient. So in an interdisciplinary team meeting, it is required to have the MD present, and it is required to have the family or patient present. Also, for physical therapists, do remember that if the patient is present, you can utilize this time. You can bill for this time. This is patient care time if the patient is pregnant. Migraine. Yeah, I can't even talk. If the patient is present, maybe they're not pregnant at the time, but so if they are present, utilize that time. And at this point, you are talking with nursing. You're finding out how much assistance they're requiring from nursing multiple times of the day. I know Kerry and I have talked about this several times together, and she has mentioned it multiple times before. Night shift is where you will have the least amount of your documentation. And I know as a therapist, it's frustrating. I can do all this work with a patient during the day. I got physical therapy in there for an hour. I got speech therapy in there. I've got occupational therapy in there for an hour roundabout. So, 2.5 hours therapies with them, but then you try to come back the next day and see what that patient did throughout the afternoon, throughout the night, and you have nothing to go by. The patient was resting comfortably. That's about all you see. If they had to get up and go to the restroom, they're not documenting how much assistance they needed. If they're in pain, they're not really documenting that as well as they could. What is actually the source of the pain? They're hurting, but where are they hurting? What's going on? They're not those night shift nursing. It's just the documentation there is not as great as it could be. And that's what you really want to focus on for those of you that are over swing bed programs. You want to make sure that your nursing documentation is also showing skill. And that they kind of coincide. Sometimes, physical therapy will document something about a patient, being minimal assistance or something like that. But we're also doing flooring. We're talking about what kind of flooring they're going over. We're talking about how many cues we're using. What kind of cues are we using? Verbal? Are we talking about tactile? Are you talking about visual? What kind of cueing are you using? Are they making any turns in the room? Is the room cluttered? Is the room, are they going straight past? Is there any deviation in the path? You want to make sure that you're documenting those type of things in therapy. But for nursing, you want to make sure that they're documenting skill as well and how much assistance they're giving a patient, because you will see differences sometimes, most of the time, with a patient during the day versus at night. And you will see differences when they work differently with therapy for some reason. They'll do more with therapy than they will with nursing. So you want to make sure that you're coordinating that and that you're documenting consistently with each other. You don't want one saying they're independent and one saying they're needing max assist. You're going to get denied for that treatment very quickly. Therapy documentation, like I said, it needs to be very specific. You want to paint a picture to these auditors and to these surveyors. I did mention cues. I mentioned surface. What kind of surface are they walking over? Is it tile? Is it wood surface? Do they have to go over a threshold? And the reason that we want to put that is because what is in their home? What do they have to be able to walk over in their home? Is it carpet? If they've been at if they've been at your swing bed facility for 2 weeks And not one time have we gone over anything but tile. You know, how do you know how they're going to do when they get home? They go home and they've got carpet an inch thick. They have to go from carpet to linoleum to tile. You know, you've got to be able to document what you've done, and you need to be able to try different flooring changes. You want to try different flooring changes so that you can document that as well. But you just need to make sure you're not saying this patient walked 300 feet with, you know, standby assist with a walker, because that doesn't tell much about how they did that. Anybody can do that. That doesn't show your skill whatsoever. So be very specific about surfaces, about the adaptive equipment, or about the adaptive device used, walker, wheelchair, cane, hemi walker, whatever it may be. Make sure that you are documenting that. Adaptive equipment, if that's being used, one of the examples I come up with, or I've come up with multiple times about this, is if you are doing transfers, toilet transfers in the skilled nursing facility, I'm in the swing bed. If you're doing toilet transfers there, how much space do you have in that bathroom? You have all the space in the world in most swing bed facilities. But when they get home, you're not going to have that much space. Are you transferring them to a elevated toilet seat, like a bedside commode that's over the toilet? If you're doing that and you're saying they're independent with that, they can go home. How does that really translate to what their home toilet looks like? They could get home and not have, you know, they have a regular toilet that's low and they get on it and can't get off of it. So we want to make sure that if you're saying, you know, we're transferring to and from a bedside or a toilet with contact guard assist, make sure that you're saying they're using a guardrail. They're using the handrail to assist in the transfer. They're using a handrail to stabilize themselves when they are performing hygiene, toileting hygiene. Make sure that you're stating that they're using a bedside commode over the toilet at so-and-so height. Just so you know, or just so anyone knows, this is what they're currently using, but that's not what they have to be able to do to go home. They don't have a grab rail at home. They don't have an elevated toilet seat at home. They don't have a room for a bedside commode to go over their toilet seat. So they currently are not safe to go home at that level. You have really got to document all the specifics. You want to be very, very specific. Another thing is standardized test. So CMS manual, excuse me, does a good job of talking about objective evidence. Chapter 15, Medicare benefit policy, it tells you that using standardized instruments are great because they show outcome measures. They show that this great objective measurement that is backed by research. It is measurable assessments that assess function. You can use objective measurements at the beginning of treatment, during and or after treatment, and it's recommended to qualify progress and support justification for your treatment. They are not required. However, they will enhance the justification for needed therapy. I did read that right out of chapter 15 because I wanted you guys to see it is not required, but their use will enhance the justification for needed therapy. I don't allow my therapist to do less than 3 standardized tests per evaluation. So we are doing 3 standardized tests per discipline. And like I said, we're reassessing those every 5 visits. So if something's not improving, we are modifying our treatment plan every 5 treatments. Okay. So those are great. And I have really found that patients love to hear their progress, y'all. So for instance, like a 1080, I have 1080 in my brain because I use it 500 times a day, but a 1080, you know, if someone knows they're at a risk for falls, I'm like, I know I did terribly. And you're like, well, you know, you only scored a 15 out of a 28. That's only a moderate risk for falls. Our goal was a 20, 25 with your walker. Well, we're going to see where we are in a couple of weeks, see where we're in a couple of days. We're going to test it again, and they will work so hard for you for that next week, and they will do so good for you. And when you tell them what their score is, they're just so excited. They're really, really excited. So I love using those, and our patients really love to hear how they're doing with their goals as well.
Amber, a couple of questions before we move on. We did have one question, but I think it's been answered. Are you seeing your patients twice a day for PT, then reassessing goals every 3 days? And also, can you please clarify the reevaluation of goals? Kind of hearing that Medicare every 30 days, but you're doing them every 5 visits. So if you could just clarify that a little more.
Yes. So Medicare requires a progress note. Okay. A progress note for Part A patients are due every 5 treatments. Okay. So it's about once a week for those that are doing 5 days a week treatment in 7 days. So every 5th visit, you will have a progress note, and you will reassess those goals with each progress note. Okay. And then an updated plan of care or recertification is required every 30 days for patients who are under Part A, who are being seen under Part A services. And I'm sorry, the first question, I missed it.
It was, are you seeing your patients? I think
that's
you've
right.
answered it. Yeah, twice a day, and then reassessing.
That's right.
Goals every
Okay.
3
The
days.
only time we will see them, we may see them twice a day, but if we see them twice a day, it is either ordered BID or it is we're splitting our treatments. Some of our patients are vent patients. Some of them are not, but if they cannot tolerate a full treatment session, then we do split it up. And we just put that we have 2 encounter notes that day, and it still flags us at the 5th visit, at the 5th day of visits. Not at every 2, 4, not every 3rd day. That's another thing about our EMR. It flags us and tells us, hey, you're ready for a progress note, and most do. Most EMRs do. So follow that. If you do have a problem with your EMR not flagging you for a progress note every 5th treatment day, then you definitely need to get with the administrator of the system and make sure they're flagging that, because those are required.
Okay. A couple other things in chat is, could you kind of share again what test you do use? Those standardized tests?
For standardized tests, yes, ma'am. So like I say, I do skilled nursing facility and I do swing bed. So between the two, depending on where the patient is going afterwards, if they're staying long-term care, or even if you have a swing bed patient that's going into long-term care, I may utilize a different tool. But most of the times, the ones that I'm using are the 30-second sit to stand test. And I'm using that to quantify strength and cardiopulmonary endurance. And when you find these, they're any, actually, I have that website. Okay. So the Shirley Ryan Ability Lab Rehabilitation Measures database, I did provide that link. I provided that link to you guys. That is, and they can share that with you. There's over 500 standardized tests on that website. It's an excellent tool. You can get just about anything, and you can actually break it down to, is this a stroke patient? Is this a vestibular patient? Is this an orthopedic patient? You can break it down and get, go to those subtitles and get you some tools that are there. It shows the validity, it shows specificity, sensitivity, what actual demographics, I guess you would say, what age, who you would use these on. It gives you the tool. Most of them are free. It gives you the tool where it tells you where you can find them, and it shows you how to score those. So I did give that link, but it's a great resource for therapists. Put it up there in your favorites bar, and you just pull it down and search balance, and it's going to give you all of these measures, all of these standardized tests for balance, pain, back pain, anything. I love that website. I use that a lot, but the ones that I do use the most are the 30-second sit to stand, Berg, Tenetti, the dynamic gait index, the elderly mobility scale. Trying to think off the top of my head. I use those predominantly. Tug, of course, we will use tug, 4-stage balance test, modified dome test, foam and dome. A lot of mine, since I do have a fall prevention background, and that is what I specialize in, a lot of mine do consist of standardized tests for falls. So,
Amber, can I
Uh-huh.
just reinforce
Sure.
what you're saying?
Sure.
For the last 5 years, I would bet that 98% of the nursing homes in this country with PTOT and speech programs, but particularly for PT, the favorites really are Tenetti, Berg, Tug, but the fourth one is the elderly mobility scale, the EMS, because the population tends to be, or was at least in the past, mostly aged. Obviously, we're getting younger patients now, but that's the other one that I've heard routinely.
And is 6 clicks a type of therapy assessment?
6 clicks.
Mhm.
I've heard of that one. I've heard of that one, but I would actually have to research that a little bit more. 6 clicks, I'm having fog right now, but 6 clicks, I would have to research that a little bit more. But if it is, you would find it there.
Yeah, it's, see, I'm not a therapist, so Amber, you're going to have to correct my language, but basically it's mobility, such as walking from one position to another. It assesses daily activities, like dressing and toileting. So basically it takes all these individual tests and shortens it into 6 basic questions. I just don't remember them all at this point.
Okay.
April has shared in chat that it is a mobility assessment, bed mobility, transfers, ambulation.
Okay.
So great.
If it's standardized, guys, then the federal government isn't going to come after you too much. But if it's short answers standardized, they're going to expect your professional opinion to be documented, as follow-up to something like that. And that's what I'm saying, Amber, for review. You can say it from a therapy standpoint.
Yes, and like I said, it doesn't require, they don't require standardized, but standardized tests, as she said, the elderly mobility score or scale, that is a great one because it is getting into the elderly population. And that does some of the same things that it sounds like the 6 clicks does. It is bed mobility, it is transfers, it is the functional reach inside of that score, ambulating 20 feet with assistance or without. So it kind of does that same mobility thing, but it is a standardized test. And it just goes to show like certain scores will show you how independent that patient would be if they were in the home, or how, in skilled nursing facility, it shows their independent level. So that is the elderly mobility scale. But the 6 clicks, I have not personally used that, no, but you can use, like I said, it's not required. Standardized testing are not required, as long as you have, it's not a subjective measurement. It's not a question answer type thing. Like Kerry said, it's more or less an objective. You have objective findings.
And Amber, we just have a couple of minutes left, so we may have to have you come back and finish your presentation, but just wanted to let you know that. So any parting thoughts like for today?
Yes. So I did have a good bit left. I never thought I would get to 30 minutes with this voice. I can't believe it. But there are some things that I did send as resources, and we probably won't have time to bring those up, but some of the things that you could do for balance and for strength as far as falls goes. Like I say, I'm huge fall advocate. So I use the Otago program. I did provide that in PDF. Please utilize that. Teach your family members, your patient's family members how to do that. Teach your patients how to use that as a home exercise program. It incorporates strength and it incorporates balance. Studies show that if you do one without the other, it's not really a significant reduction in falls. You have to really do both. So that Otago program, I've provided that. That's great. Utilize families, like I said, as much as possible. When you are short-staffed in a rural area, it's hard to get to home evals. We do home assessments. If you can do those are great. If you do not have the ability to get a therapist out to complete a home assessment, then utilize the family members. I have also provided a handout from STEADY, which is put out by CDC. It's the Stopping Elderly Accidents, Death, and Injuries group. And they have a home checklist, a home hazard checklist that's super easy for your families. You can hand this to them, take this, let them take it to your patient's home, go through all these things, because if they don't have this in hand, they're not going to think to look at, let's see, has the stairway light burned out? You may have 3 lights there and now they're only living with 1, and you don't realize how much of a difference that makes until you put those 3 lights back in there. It's just little things like that, thinking outside the box, that these families really have to do to prevent these falls when they go back home. But not only that, they can go ahead and get all those hazards out of the way, but your patient might say, well, I don't even know if I can get on and off my bed. Have them measure the bed, have them measure the height of the bed, have them measure the height of the tub, have the families really help you out. Go in with FaceTime if you need to, and have have a look around the house. Have them measure the distance between the tub and the toilet. I feel like that's the biggest area. That's where a lot of our patients fall, but that's also the smallest area in the house where they're going to get trapped. So have them measure that to see if we need or if we would even be able to put a bedside commode over that, a 3-in-1 commode. Let them be your hands and your eyes and your ears out in the patient's home. That's going to reduce risk for falls and readmissions in the future. Like I said, they could take pictures of the furniture, see how high they are, see how low they are, measure the dining room chair. Is the dining room chair, how high is it? We've been doing sit to stands from this mat table and from this hospital bed 300 times. But when they get home, if their chair is 17 inches high, they might not be able to get off of it. So you've got to think about those things. Provide families with resources. Like I say, this STEADY handout, let them know about community programs, gym programs, ours here is Silver Sneakers. Give them information on keeping the patients hydrated when they go home. That's the big thing. Dehydration and urinary tract infections, especially if that's what they keep coming to you guys for. Is that what initially caused the fall? Let's treat the bottom line here. Let's treat the urinary tract infections. Let's treat the hydration issues. So provide them with handouts specific to diagnosis and conditions. Diabetes, from one. Use your skill to give them information about how to do skin checks, how to, what kind of shoes to wear, what kind of socks to wear, what kind of things to avoid. Don't go to the local nail salon to get your toes done. Give them different information and different recommendations, resources for those things. Dementia is a big one. Some of these residents some of these patients' families have never had to deal with dementia, and they don't know how to do it. So provide them with information. Again, that is skill. Use your skill to help these patients better, help these family members better take care of the patients when they get out in the community, and hopefully they won't have a readmission. Medication management's another huge one. But just try to think outside the box on things. Telehealth is another thing. I'm trying to hurry. I know telehealth is another thing that we as therapists are allowed to do in Georgia. I'm not sure if you're allowed in Indiana. I did also provide the Medicare approved codes for telehealth. These codes are approved through December 2023 so far, and they are extending that past COVID. They were originated, I think, for COVID for therapists, because we used to not be able to do them. but they're actually collecting data to see if this is actually going to be a good thing for us and for them. These telehealth visits. So use them while you can. You can use them if you're low staff with a registered therapist. They can do telehealth visits for their supervisory treatments. That's just a couple things. I know I feel like I'm running through it now, but if any of you guys, she has my email, Miss Becky has my email, please reach out with any questions, any concerns, anything, any questions any resources you like, or anything, want to know how I do things with certain treatment methods, or if you want me to throw some ideas out to you. I know you've got one seeing seeing occupational therapy and may not be seeing PT or vice versa. Let me throw some options at you to go check on, and see if you maybe can treat those patients as well. I had so much more, y'all, and I'm so sorry I'm sick today. I'm usually not this just kind of foggy and messy, and I do always sound country, but I don't always sound like a man. So I'm so sorry, but thank you for
It's
listening.
been wonderful, Amber, and maybe we can have you back to kind of finish up with some of the discussion that you had planned. We had lots of good questions, and I think the information you've shared has been very helpful. Kerry, any parting words before we jump off today?
No, I'm actually just feeling very relieved, Amber, about what I teach is pretty much what she just said as a therapist. And I think the main thing, she brought up the second shift nursing documentation is just critical on review, that the services you're providing during the day are needed because these guys are not safe at night. And that's true of most hospital patients. The second thing I really like about having Amber on, and so we'll bring her back on, is the creativity, that you don't do the same thing over and over with every single patient. We've talked about 65-year-old males being admitted with a hip fracture, and you just can't treat them the same way. And that documentation has to show that. So I know, Becky, we had a couple other questions. I don't know if we have time for them that were raised.
For those that would like to stay on, there have been some questions that have come up from more than one hospital recently, and just wanted to cover them. So stay on if you can. If you can't, we will be sending out the recording. But Kerry, if you could cover the billing for physicians versus a hospitalist versus advanced practice nurses, what's appropriate for swing bed billing for these groups?
It would not be by the setting, it would be by the standard billing practices for each of those. Becky, I sent a billing summary for some of that to you. It's an MLN, so it's an official Medicare document. Let's see if that answers whoever's asking that question, answers that question. If it needs to be answered more specifically, then I will get one of my billing experts to send me some responses and or materials that would help with that.
Okay, and I'll distribute that MLN with the follow-up of the recording as well. And if a patient is being readmitted from a swing bed, do they, because their condition had deteriorated, is it necessary for them to go back to the emergency department prior to being readmitted to the hospital? Or is that part of the advantage of having a swing bed program, that you could send them right back either to an acute or critical care area?
Yeah, that is one of the advantage. So basically the simple rule is that even if the patient has been discharged from the swing bed, within 30 days, they can return to your swing bed and they do not have to go through ED or another hospital stay. It's a clinical question. If they are unstable, then maybe the ED is the best place, because that's what we use, for all of our settings for stabilization, and a determination can be made. However, if it's related specifically, I'll say a surgery, and maybe now there's an infection you're worried about or whatever's going on with that surgery, then there's nothing that keeps them going from the swing bed right back to acute status. So your physicians will be key in this, and I think educating physicians particularly, within the walls. They can go down to ED and still be a swing bed patient. So physicians need to know that. And I think we need to do more education that if somebody within the 30 days needs to come back and it's directly related to the acute stay that put them in the swing bed, they can come right back into the swing bed. So there's a lot of flexibility in this one setting that we don't see in any other setting between, federal regulations. Is that clear, Becky?
I think so. Couple of questions that popped up in chat. Can the ER treatment and testing be billed under the swing bed account?
The general rule for critical access is any services provided to a swing bed patient while they're under that licensure would go on the swing bed claim. That includes surgery, et cetera. So that would fall that way as far as I know. I've never seen it done separately.
Okay. And April, I think your question is related to the patient being readmitted. She asked the question, is that for traditional Medicare and Medicare replacement plans or both? So does that apply?
Well, Medicare replacement plans are supposed to follow the skilled rules, which are Medicare. They're, the federal rules for those kind of choices. Having said that, replacement plans are taking, I think, a lot of liberties these days in determining and defining things. So I might, as a safety valve, have, your contact with the Medicare replacement, whether that's a discharge plan or whoever, call and double check. Better yet, if you can send an email, then you get an answer in email, then you have something in writing, to defend why you did that choice. But legally, the replacement plans are Medicare. It should be just a structured difference as far as payment and some of the extra advantages that individuals get under that. So it should follow Medicare A traditional rules. But I'm wary these days. I'm watching so many things kind of change rapidly that if you have a fair amount of advantage plans, and we're seeing more and more of it in rural areas, then again, I would try and get something through an email so you have it in writing and keep it handy.
One last question, if we could then. Can OT and PT co-treat when appropriate for swing beds? And if so, how do they bill for that?
I have not seen it done that much in skilled, but the answer is yes. They can co-treat by the by the federal regulations. And Becky, sometimes there are state regulations on that too, so that might be something you'd want to check for Indiana. The co-treatment then would follow the federal guidelines for splitting time.
Okay.
As far as getting reimbursed. You can't get reimbursed, if both of them are co-treating for a 15-minute period, both of them cannot claim 15 minutes, as you know.
Right. Okay. Well, that's all the questions that we have. Be watching for the follow-up email with the recording, some important links, and I'll reattach the tools that were forwarded earlier today that Amber shared. And Amber, thank you so much. Today's been wonderful. And Kerry, just so appreciative of you pulling in Amber and having her share her out-of-the-box thinking with us. And so we'll continue to have these discussions. So
Yes,
have a
thank you for having
wonderful, great. Have a wonderful Valentine's Day, everyone, and stay safe. Thank you so much. Bye-bye.